Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I wanted to discuss with you a case scenario about case of abnormal uterine bleeding. Let's start our journey with the case scenario. A 39-year-old, second gravida, second para woman, referred to outpatient gynecology clinic and presented with increasingly heavy periods with blood clots for 4 months. She continued to have a regular 29-day cycle, but her period lasts for 10 days each month, and her daily activity were interrupted. She wasn't experiencing any intermenstrual or postcoital bleeding, but had a feeling of heaviness in the pelvis. She had no other medical disease, and she is not a contraceptive user for 1 year till today. Okay? So, first, what is the key word in this case scenario? The age of the patient is important, yes. She is 39 years, she is in a childbearing age, and she is not using any contraception. Okay? She has 2 babies, she delivered twice. Okay? Age is important because there is a common etiology in child bearing age for abnormal uterine bleeding. Okay? Okay. What is the pattern of bleeding here? This pattern of bleeding here, as you see, heavy menstrual bleeding. The, the period continue for 10 days. Of course, more than 8 days is abnormal. Also associated with blood clots and also interfere with daily activities. This means that the amount of blood loss is large that interfere with daily activities. What about the cycle? Is it regular? Yes, it is regular, recurring every 29 days. Is there any intermenstrual bleeding? No. Is there any postcoital bleeding? No. Of course, postcoital bleeding is important to exclude cervical lesions like cervical ectomy, cervical carcinoma, CIN3, okay? Okay, or cervical lesions like polyp. The patient has a feeling of heaviness. Maybe there is organic pelvic lesion, maybe. Also, what is important here in such case that she is not using contraception, because if she is IUD user, for example, maybe a cause of heavy menstrual bleeding, but she is not using contraception. Okay? And she has no medical disease, and this is important also because some medical disease may be associated with abnormal uterine bleeding, like bleeding disorder, blood diseases, like liver diseases, like thyroid dysfunction, and so on. Okay, so to reach the diagnosis, we should complete the history, full history taking, and do general examination for such case. Searching for what? Searching for any evidence of bleeding tendency, general causes, like bleeding disorder. There may be pubic eruption, ecchymotic patches in the body. Examination of the eye, there may be jaundice, yellowish discoloration of the sclera, yellowish skin, liver diseases. and also searching for any thyroid mass, because thyroid dysfunction may be a cause of abnormal uterine bleeding. Okay, and complete the general examination as usual. Then we are going to do abdominal, then pelvic examination. Abdominal examination to exclude any abdominal mass. Then pelvic examination will concentrate on what? On the presence of uterine mass or ovarian mass. And if there is uterine mass, how can I differentiate it between uterine mass from ovarian? Uterine mass, its mobility transmitted to the cervix, while the ovarian mass is not. In uterine mass, there is no sulcus between the mass and the uterus, while in ovarian mass, there is sulcus between the mass and the uterus. Uterine mass usually in the midline, while adnexal or ovarian mass in one iliac region. Uterine mass mostly firm in consistency, while ovarian mass usually cystic, more common. Okay? If the uterus is enlarged, is it symmetrical or asymmetric? Symmetrically enlarged uterus may be in the pregnancy or in submucous fibroid or in hematometria and so on and so on. Asymmetrically enlarged uterus may be in subserous uterine fibroid, also in focal adenomyosis. But diffuse adenomyosis will give me symmetrical enlarged uterus. Okay? Okay. So, what is next step? Next step is to do some investigation to reach a diagnosis. From history examination, you should reach about 80% of the diagnosis. For example, you found the uterine mass, you suggesting uterine leiomyoma, but still you wanted to confirm by using ultrasound, for example. So, investigation needed in such a case will be two main categories, lab one and imaging. What is important in lab in such case? The first is to exclude pregnancy because the patient, if you remember, she is 39, she is in childbearing age, so we should exclude pregnancy complication. So we will do pregnancy test, specifically serum beta HCG. Okay, we excluded the presence of pregnancy, that's complication. Go to the next, we ask for CBC. Why CBC is important? To diagnose thrombocytopenia, to diagnose anemia. Then coagulation profile test for bleeding disorder to be diagnosed. INR, thrombin time, bleeding and the clotting time, and so on. Okay? Then go to the imaging. What is important in imaging is the ultrasonography, abdominal and transvaginal. In case of small mass, transvaginal ultrasound is much better. Give me an accurate and better resolution than abdominal ultrasound. So the resolution of the image is better with transvaginal sonography. Abdominal ultrasonography is important in case of large mass, more than 10 centimeter, becomes pelvic abdominal mass. So to see all boundaries of the mass, we should do abdominal ultrasound. In small mass, you can do only transvaginal sonography. And as I said, the advantage of transvaginal sonography is very near to pelvic organ. It has a high frequency with better resolution than abdominal ultrasound. Okay? Transvaginal sonography can diagnose accurately fibroid and detect which type of fibroid. Is it submucous, intramural, subserous, and the grade of fibroid could be detected according to FIGO classification from L1 to L7. Saline infusion sonography is important to diagnose some cases with intracavitary lesion, like endometrial polyp, like submucous fibroid, like intrauterine adhesions, and so on. So saline infusion sonography, if I cannot reach the diagnosis of TVS, I can do saline infusion sonography by inserting a Foley's catheter inside the uterine cavity and injecting saline inside the cavity, 10 ml of saline, and doing transvaginal sonography. The cavity can be seen of the uterus, and any intracavitary lesion can be detected very well. So you shouldn't ask many investigations. You should ask the investigation which leads you directly to the diagnosis. And the good doctor who asks very specific investigation to reach the diagnosis, and they're not exhausting the patient and the system with many unneeded investigations. Okay? So after we did that, we found in this patient anemia, hemoglobin 9 gram percent, and all other parameters of CBC was normal rather than anemia. Okay, coagulation profile was normal. Imaging by TVS was quite sufficient to diagnose the case as a submucous fibroid, type 1 fibroid. Okay, so the diagnosis, how can I say a complete diagnosis in gynecology? A complete diagnosis in gynecology should include anatomical, etiological, and functional diagnosis. Before I start, I should give some comments on the causes of abnormal uterine bleeding. According to FIGO 2011, they divide it into Balm coin classification, two main groups. Balm, this is abbreviation, P for polyp, A for adenomyosis, L for leiomyoma, M for malignancy and endometrial hyperplasia. Coin, this is abbreviation for C for coagulopathy, O for ovulatory dysfunction, E for endometrial causes, not organic, iatrogenic, letter I for iatrogenic causes like COC, pills, like intrauterine device, like, and so on, iatrogenic. N for not yet classified. And under this category, they put ismocele, and some put also arteriovenous malformation in the uterus. Okay? So, not yet classified may include the ismocele or AV malformation. As you see, here we are talking about the Balm coin classification. In the Balm, this is Balm for organic lesion, coin for functional lesion mainly. Okay? Okay, let us reach the diagnosis of our case. Anatomical diagnosis. This is an abnormal uterine bleeding. Okay? The form of heavy menstrual bleeding. Etiological diagnosis. Is it fibroid? Is it adenomyosis? Is it polyp? This is the common lesions. Okay. In our case today by TVS, we confirmed the presence of leiomyoma type 1. What is the functional diagnosis? This continuous every month bleeding for 4 months resulted in anemia. Anemia could be a result of heavy menstrual bleeding, long-standing cases, and also could be a cause of bleeding, okay, as a general cause. Okay, so what is the diagnosis of our case? Abnormal uterine bleeding due to type 1 uterine fibroid, which is L1. And this is one of the submucous fibroid categories. Fibroid categories including L0, L1, and L2. And this mass was 4 centimeters, detected by ultrasound, and associated with anemia. This is the complete diagnosis of our case today. What is the best treatment as regards the patient in childbearing age and she wanna to preserve her uterus? She may need children, so the best management will be hysteroscopic resection of this small type 1 uterine leiomyoma. Okay, this is the last slide. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.